Hi, my name is JGreen, and this is my oral midterm presentation for Professor Turner's Composition 2 class. I chose to research genetic testing for breast cancer susceptibility gene mutations, which are otherwise known as BRCA1 and 2 mutations, with a comparison of the advantages of testing to the potential psychological effects. I chose to research this topic because I am currently pursuing a degree in radiologic technology with intention of specializing in mammography, and because I have a family history of BRCA1 and 2 mutations, and I wanted to have a better understanding of the decisions that my family is faced with. Critics say that women should not be genetically tested for BRCA mutations because the psychological effects of testing do not outweigh the advantages. I say that physicians, employers, and society strongly encourages healthy lifestyle choices. And I view genetic testing should be the same, where an individual takes a proactive stance to understand their potential health risks and follow a regimented screening process or choose a prophylactic measure that may save their life. This presentation is intended for anyone with a family history of breast cancer, whether it be male or female. You see, each one of us has BRCA genes, which are tumor-suppressing proteins. But when these genes are mutated, they significantly increase the risk of developing breast cancer and other cancers. My research focuses on women with BRCA mutations and the risk of breast cancer. However, it is important to note that the National Cancer Institute recognizes that BRCA mutations can cause breast, ovarian, fallopian tube, peritoneal, prostate, and pancreatic cancers. It is my hope that this presentation provides a better understanding of BRCA mutations, the associated risks, and the available options. I expected to find that more women are being tested for BRCA gene mutations as awareness for breast cancer and associated risk for carriers increase. And of those tested, the preferred option for BRCA mutation carriers is additional early detection screening regimen compared to radical prophylactic measures. While there is a potential for psychological effects associated with testing, screening, and prophylactic measures, the benefits do outweigh the psychological effects. The National Cancer Institute reports that about 12% of women without BRCA mutations will develop cancer sometime during their lives, but the risks significantly increase among BRCA mutation carriers. It's estimated that 55 to 65% of women who inherit BRCA1 mutations and around 45% of women who inherit BRCA2 mutations will develop breast cancer. For BRCA mutation carriers, when accompanied with other risk factors, the risks are so extensive that the question is not will I develop cancer, but when will I develop cancer? Understanding the increased risk of developing breast cancer, it is no wonder why some critics believe that identifying the risk through genetic testing will cause psychological effects. The North Carolina Association for Biomedical Research claim that critics feel the uncertainties surrounding the test interpretation and the test's potential for provoking anxiety could outweigh the benefits of genetic testing. In the article, A Counseling Model for BRCA1 and 2 Gene Susceptibility Testing, Drs. Van Oostrum and Tibben, who are affiliated with medical psychology and human and clinical genetics, address the need for appropriate protocol and multiple counseling sessions when performing BRCA genetic testing, administering the results, and they discuss the potential psychological impacts associated with testing. The authors reported the results of studies from genetic testing for BRCA1 and 2 mutations, which after a 5-year follow-up with the patients indicated that the mean level of psychological distress remained underneath the clinical threshold. Another study noted that few of the 253 women evaluated reported psychological distress because of testing. I agree that some psychological effect can be contributed to genetic testing, but I imagine that these effects are so much less than the psychological effects of dealing with an actual cancer diagnosis, especially if it is found in late stage. As I mentioned earlier, I have a family history of BRCA1 and 2 mutations, and I have never been tested, but not because I fear depression or anxiety. I really just did not want to know. But after completing this research, I have determined that this is a selfish prerogative, and I may be putting my life as well as my son's and grandson at risk. Again, the focus of this paper is testing in women. However, it is worth noting that men potentially benefit equally from testing, as they would not normally rely on standard mammography for detection of breast cancer in the same fashion as a woman. Genetic testing provides early cancer detection screening options including mammogram, ultrasound, and MRI. And in the article, An Update in Breast Cancer Screening Management, Dr. Sanjay Warrior and associates, who are affiliated with the Department of Breast Surgery and Medical Oncology, addressed early detection screening alternatives. And the authors acknowledged that in 2010, the Society of Breast Imaging and the American College of Radiology recommended annual MRI screening as a supplement to annual mammography screening for BRCA carriers. This recommendation came after a 2007 recommendation from the American Cancer Society, which was based on 9 trial results. Typically, insurance companies will provide 1 free mammogram a year. An MRI can be expensive, and in instances where the insurance company will not cover the supplemental MRI, ultrasound can be used in the alternating sequence. Most insurance providers will cover an ultrasound, and it is less expensive means of imaging. And in my personal experience, physicians will recommend the same sequence for patients with a known family mutation, regardless of whether the patient's mutation status is known. There have been several clinical research studies conducted to determine the effectiveness of surveillance methods for early cancer detection in BRCA mutation carriers. Kelly Metcalf and associates affiliated with multiple cancer institutes in Canada presented their findings of a 2013 study which focused on the recommendations of 70 genetic healthcare providers in Canada. 4 scenarios listing varying age and BRCA mutations were presented, and the ranking options included prophylactic mastectomy, prophylactic oophorectomy, tamoxifen, and screening. The results showed that the healthcare providers recommended screening methods for BRCA mutation carriers over prophylactic mastectomy or tamoxifen. Mohammed Salhab, Selena Bismohan, and Kifa Mokbul, affiliated with the St. George's University of London and London Breast Institute, cited a study of 139 women with BRCA mutations. After a 3-year follow-up, breast cancer developed in 8 of the 63 who had elected surveillance and none in the 76 mutation carriers who had undergone prophylactic surgery. This case study demonstrates the effectiveness and the benefit of both surveillance for early detection and prophylactic mastectomy. Tamoxifen, a prophylactic chemotherapy, is another option for BRCA mutation carriers. In the article Hereditary Breast and Ovarian Cancer Review and Future Perspectives, obstetric and gynecologic physicians Lux, Fashing, and Beckman discuss the success of prophylactic measures for BRCA mutation carriers and describe a study noting that the use of tamoxifen reduced the incidence of breast cancer by 62% in BRCA2 mutation carriers. However, there was no influence on the risk of BRCA1 carriers. Prophylactic mastectomy is another option that BRCA mutation carriers have to potentially significantly reduce the risk of inherited breast cancer. Doctors Heiss and Chen, associated with gynecologic oncology at the University of California, report that prophylactic mastectomy can reduce the risk of breast cancer for BRCA mutation carriers 90 to 100%. And while these reduction statistics are high, Dr. Heiss and Chen also suggests, though, that prophylactic mastectomies can have psychological risks, especially regarding femininity and body image. In a study and interview process conducted by Dr. Charlene Heiss-Bibber, who was a sociology professor of Women's and Gender Studies program director, the results concluded that 3/4 of the BRCA-positive women interviewed elected to have preventative mastectomy. And she also pointed out that emotional worry and fear are strong predictors that propel BRCA-positive women to elect prophylactic surgery, and also that the experiencing the death of a loved one, which was caused by breast cancer, was a leading factor in their decision to have prophylactic mastectomy. On the contrary, Dr. Pruthi, Gustow, and Lindor, affiliated with Mayo Clinic in internal medicine, obstetrics and gynecology, and medical genetics, reported a study in which 74% of women had a decreased emotional concern after a risk-reducing surgery and had favorable psychological and social outcome. There have been several clinical research studies conducted to evaluate the effectiveness of the risk reduction mastectomy among BRCA mutation carriers. Lux, Fashing, and Beckman reported findings in a study conducted by Hartman and affiliates where no breast cancer developed during a follow-up period of 13.4 years for 26 carriers who underwent prophylactic mastectomy. Prophylactic mastectomy may seem like a radical approach to some, but the surgery significantly reduces the risk of breast cancer among BRCA mutation carriers and empowers them to potentially live a healthy life without the worry of a future breast cancer diagnosis. Based on the research that I found, I determined that women with BRCA mutations do experience psychological effects from testing, whether the results are positive or negative. However, the reported numbers are minimal. Each individual patient should be evaluated prior to genetic testing, as some pre-existing psychological factors may exist that in which testing may not be the best solution for that individual. But genetic testing for BRCA mutations provides the patients with the ability to determine their own personal mutation status and make an informed decision about their own health and welfare. Knowing your BRCA status provides opportunities to take proactive measures that may not have existed prior to testing, to pursue additional intensive screening methods or prophylactic measures that provide further benefit to the patient tested. While there is a debate that clinical breast exams alone may not be sufficient to catch breast cancer early enough, these exams in combination with alternating mammography and MRI have been reliable sources in early detection of breast cancer in BRCA carriers. On one hand, prophylactic mastectomy may seem like a radical measure leading to life-altering changes and potential emotional distress in the way that the woman perceives her own femininity. But on the other hand, it provides a sense of freedom from the potential battle that women are forced to fight when faced with breast cancer diagnosis. Most women addressed in the studies felt secure in the risk-reducing procedure and enabled with the opportunity to focus on other aspects of their lives. For women who did not want to pursue surgery but still wanted to take a more proactive means, tamoxifen proved beneficial in reduction of cancer risk for BRCA2 patients. A BRCA mutation diagnosis does not define a woman, but it empowers her to take a proactive stance in decision-making that may save her life. Genetic testing is a personal choice, but it enables a woman to make an informed decision about her health, and the advantages of potential early breast cancer diagnosis or a risk-reducing measure leading to a cancer-free life does outweigh the possible psychological effects of testing. Thank you for watching.